When cancer strikes the esophagus, or when severe conditions like end-stage achalasia permanently destroy its function, the definitive surgical response is an esophagectomy. The operation must achieve three specific mechanical objectives. First, surgeons must completely cut away and extract the compromised segment of the esophagus along with its surrounding local tissue. To replace that missing segment, the patient's own stomach is released from its abdominal attachments and reshaped into a narrow conduit. Finally, this new gastric conduit is elevated upward into the chest cavity. The connection created between the remaining healthy esophagus and this new tube is called an anastomosis, restoring the continuity of the digestive tract. Executing these steps requires navigating the deepest, most restricted core of the human body, where the boundaries of the neck, chest, and abdomen converge. This diagram maps the operative field across three distinct anatomical zones: the abdomen, the thorax, and the cervical region, or neck. Because the esophagus spans all three areas, the surgical classification of an esophagectomy is dictated entirely by how the surgeon chooses to access those zones. That choice of access relies on two primary variables. The first is the precise anatomical location of the tumor. Location dictates the margins, exactly how much healthy tissue must be removed to ensure oncologic clearance. The second variable is the baseline physiological health of the patient, specifically their respiratory function and ability to withstand major trauma. Every esophagectomy forces the surgical team into a high-stakes calculation, balancing the geometric need to clear the cancer against the physiological cost of rebuilding the digestive tract. For tumors located in the lower esophagus and gastroesophageal junction, the standard approach is the Ivor-Lewis procedure. This two-stage geometry begins with a first incision in the abdomen to free the blood supply and shape the stomach into its new conduit form. The thoracic phase tackles the disease itself. Working through a second incision on the right side of the chest, a right thoracotomy, the surgeon resects the diseased portion of the esophagus along with the surrounding local lymph nodes. Because the tumor was located lower down near the stomach, surgeons do not need to remove the upper reaches of the esophagus. They have direct, localized access to reconnect everything inside the chest. The stomach conduit is pulled up, and an intrathoracic anastomosis is created. Moving this connection point deep inside the chest cavity carries a specific risk. If the anastomosis leaks as it heals, a leak inside the enclosed space of the thorax is difficult to manage. The Ivor-Lewis approach provides excellent visualization for clearing distal tumors, but requires the primary healing joint to sit deep inside the enclosed chest cavity. If a tumor is located higher up, in the middle or upper third of the esophagus, the required surgical geometry changes. These tumors demand wider proximal clearance margins. The surgeon must remove a significant perimeter of healthy tissue above the disease segment to ensure all microscopic cancer cells are eradicated. This anatomical necessity requires the McCown procedure. Here, the geometry expands to a three-stage approach: one incision in the abdomen, one on the right chest, and a mandatory third entry in the cervical region. Instead of stopping inside the chest, the gastric conduit is pulled completely through the thorax and all the way up into the neck. Because of this high resection, the new connection, the cervical anastomosis, must be established entirely within the neck. If this connection leaks during healing, a leak in the neck is structurally safer and much easier to manage than one in the chest cavity. The McCown strategy is a calculated trade-off, enduring a more extensive three-stage surgical trauma in exchange for superior oncologic margins and a safer leak profile. Sometimes the limiting factor is the patient's physiology. Patients with heavily compromised lung function may simply not survive the trauma of having their chest cavity opened. For these cases, surgeons use the transhiatal esophagectomy, a strict two-incision strategy explicitly designed to bypass the chest wall entirely. To remove the esophagus without a chest incision, the surgeon performs a blunt dissection. They work blindly upward from the diaphragmatic hiatus in the abdomen and downward from the neck, allowing the two paths to meet in the middle of the mediastinum. Similar to the McEwen approach, the reconstruction culminates in a cervical anastomosis in the neck. Bypassing the thorax directly reduces pulmonary complications, but at a severe cost: poor visibility. Without an open chest, the the surgical team cannot comprehensively clear out the network of thoracic lymph nodes where cancer cells hide. The transhiatal approach is the ultimate physiological compromise. It prioritizes immediate respiratory survival for fragile patients over maximal visual clearance of the disease. There is a final anatomical outlier to account for: tumors strictly bridging the stomach cardia and the very distal part of the esophagus. Here, surgeons employ the left thoraco-abdominal approach, a highly targeted single-incision strategy sweeping across the left abdomen and directly up into the left lower chest. Opening this specific continuum allows both the resection of the tumor and the reconstruction of the digestive tract to occur exclusively in that local space. This approach demonstrates surgical geometry adapting to highly localized disease, minimizing the need to enter multiple anatomical zones. Today, surgical evolution focuses on achieving these exact same pathways with less collateral damage, bringing us to minimally invasive esophagectomy, or MIE. Instead of large open incisions, NIE uses camera-guided laparoscopy in the abdomen and thoracoscopy in the chest to shorten recovery times and lower postoperative pain. The current iteration of this logic is RAMI, Robot-Assisted Minimally Invasive Esophagectomy. These systems provide surgeons with high-definition 3D visibility and mechanical wrists that articulate with extreme precision. But MIE and RAMI do not invent new surgical pathways. They utilize the exact same access zones and geometric logic as the classical open approaches. While robotic technology successfully minimizes the trauma of entry, the actual spatial geometry of the resection remains rigidly dictated by classical anatomical rules. This table shows how preoperative planning requires the surgical team to consolidate all of these disparate variables into a unified clinical decision matrix. The Ivor-Lewis targets lower tumors using abdominal and chest incisions for an intrathoracic anastomosis. The McCown treats mid to upper tumors via 3 incisions, pulling the connection up for a cervical anastomosis. For patients with poor lung function, the transhiatal approach bypasses the thorax entirely for respiratory safety. The ultimate choice of procedure is a calculated optimization. The surgical team balances maximal oncologic clearance against the specific morbidity risks of the individual patient. Ultimately, the procedure demands that the surgeon adapt rigid anatomical rules to the specific pathology of the cancer and the unique physiology of the patient.